if we just ask the client, how's your pet doing? Well, most often, unless they have a real problem, they're going to say, oh, he's doing great. And that client is watching that dog 100 times a day or more, right? And so they miss some of the subtle changes. Veterinarians, and hopefully we're getting clients in twice a year, we can pick that up.
Hey, VetFolio Voice listeners, thanks for tuning in to another great episode. This one's sponsored by Boehringer Ingelheim Animal Health and featuring Dr. Danny Joffe, here to talk about canine osteoarthritis and the complex role of inflammation in its development and progression. With the availability of newer treatments such as anti-NGF monoclonal antibodies, we're faced with new questions about managing inflammation associated with osteoarthritis. For years, NSAIDs have really been our go-to therapy, and these medications still play a vital role in treating osteoarthritis. But how exactly do we use NSAIDs and injectables like anti-NGF monoclonals together? Should we use them together, and at what stage of OA? And what does that mean for our other multimodal therapies like joint supplements and Adequan? Dr. Joffe and I dove into all of these questions and more, and I hope, like me, after listening this, you're able to take away some useful pointers for how to most effectively use our multimodal therapies that we've been familiar with and comfortable with for years while incorporating therapies like anti-NGF monoclonals. And I hope after listening, this episode sheds some light on the different types of inflammation involved in osteoarthritis and what we're doing with these medications in order to address them so we can create an effective treatment plan for our patients. Let me introduce Dr. Joffe, and let's go ahead and dive in. Dr. Joffe graduated in 1985 from the Western College of Veterinary Medicine. He became the first practicing small animal specialist in Alberta in 1992. Dr. Joffe has been past president of the Alberta Veterinary Medical Association, as well as past president of the Canadian Academy of Veterinary Dermatology. He presents over 150 hours of continuing education annually, both nationally and internationally. And he's published 14 scientific papers in the peer-reviewed veterinary literature. Dr. Joffe has been with the Care Center since it opened in 2006 and was the medical director of the facility from 2006 to spring of 2020. He's currently the vice president of medical operations with VCA Canada. All right, let's go ahead and jump into our talk.
Nutrition is the cornerstone of our patients' health and happiness. The veterinary healthcare team should be the ultimate source for top-notch pet nutrition info. When clients see how the right diet helps their pets stay healthy and happy, they visit us more often. Remember, good nutrition is essential. It's smart business and great medicine. Enroll in the NAVC Pet Nutrition Coach certification today on vetfolio.com.
In this episode, I'm joined by Dr. Danny Joffe, and we're going to talk about osteoarthritis. And I feel like we have kind of a unique topic here to cover when it comes to osteoarthritis. So, Dr. Joffe, thank you so much for joining me.
Thanks for having me.
So happy to have you here and to learn more about this. There's been a lot of talk about osteoarthritis lately, particularly with respect to inflammatory pathways and the role of inflammation in osteoarthritis. So I'm wondering if, just to start out, you can review the inflammatory pathways that we're talking about when it comes to osteoarthritis.
Right. And one of the major pain areas in osteoarthritis is inflammation. And sometimes we forget about inflammation. And Librela's come on the market, and that's a wonderful drug, works amazingly well, helps a ton of pets. But the one thing that sometimes we forget is that there's still inflammation left over. Librela does not deal with all of the inflammatory conditions that go along with osteoarthritis. So it's important as clinicians that we make sure that we haven't just made the dog somewhat better. We want to make them fully better. And that's what I hope we can talk about.
Absolutely. And this is what's so interesting to me, because this is a big question I've had when we're talking about the monoclonal antibodies, is we talk about neurogenic inflammation and, monotherapy versus not. And that's been a big question in my head of, if we're addressing neurogenic inflammation, are we addressing inflammation as a whole? Because I like what you're saying about we don't want to make them partially better. We want to make them all the way better. And of course, despite our best efforts, this tends to be a progressive disease. So we want to make sure we're controlling as much inflammation as possible. So can you elaborate on those pain pathways and just kind of how we go about addressing those different inflammatory mediators?
Yeah, and again, inflammation is one of the major causes of pain. And again, Librela takes care of nerve growth factor and that area, but it doesn't deal with ongoing inflammation if there is. And, maybe we'd have a young pet with early arthritis that someone identifies and they give them Librela, and maybe we're lucky and that's all we need to do. But the majority of dogs, especially dogs as they're getting older and as their arthritic conditions are getting worse, again, the inflammation is not completely taken care of with Librela. We need other things to use, and the logical thing to use are well-designed NSAIDs and NSAIDs that we're comfortable using. And so I think there's a great place in dogs with chronic osteoarthritis. There's a good place for Librela, but there's also an important place for our licensed NSAIDs that we have available to us as well.
Sure. That makes sense. And I love that you mentioned, a young dog that we diagnose and, maybe we do treat with an injection and we're good to go, because part of the conversation around osteoarthritis is that this is not necessarily an old dog disease. We're finding this in younger dogs as well if we're looking for it. And I think, part of the way we're finding that is through doing an orthopedic exam on many of our patients. But I know, at least for me, when I say orthopedic exam, I kind of get scared. I'm like, oh gosh, do I even know how to do like a good orthopedic exam? Would I even do it right? So could you walk us through the role of the orthopedic exam, maybe from a symptomatic patient's point of view and from incorporating that into a regular annual exam, more as like a screening tool, and how to use that and do that properly?
Right. And I think it's critical that we do an orthopedic exam on every patient that comes in. If we just ask the client, how's your pet doing? Well, most often, unless they have a real problem, they're going to say, oh, he's doing great. And that client is watching that dog 100 times a day or more, right? And so they miss some of the subtle changes. Veterinarians, and hopefully we're getting clients in twice a year, we can pick that up. And so that's really important. And I think every examination, what I like to do involves both a gait analysis, and what I'll do, my general practice is fairly small. Luckily, we have a sidewalk outside, and I'll go out with the clients, obviously with the pet on a leash, and have them walk the patient back and forth several times. And if they're able to jog a little bit, I'll have them do that. And often I can pick up things from that. Then we go into the examination room, and part of what I'll do in there is a full orthopedic exam where I assess every joint in the body. I check for a muscle loss, because again, that's something that the clients don't pick up. And if we don't assess for it, again, if we're talking about the hind limbs, what I'll do, again, I will use a tape measure, but in these cases, I'll often just put my fingers around the joint and see how muscular they are. And if one side is much more muscular than the other, then there could well be something going on. And I do pick up early osteoarthritic disease before the client even realizes it. And again, often when I ask them questions and I say, is he creaky and he first gets up? She says, yeah, he's getting a little lazier as he's getting older. I noticed that it takes him a minute or so to get back to full gait. Well, that minute or so is because they're in pain and they have inflammation, and we need to do something about it. And so again, I do the gait analysis, I do my full physical exam. But part of my full physical exam is the orthopedic exam, and assessing all the joints, all the musculature, all the movement that we can do. Again, I want to make sure that they'll flex to the right amount and go from there. And when clients ask about that, and I tell them what we're doing, and I actually tell them what I'm going to do beforehand so they're not surprised, they are seeing that this is value for them and value for their pet. A lot of clinicians only assess orthopedic issues when there's orthopedic disease. I want to find it early, and I'm hoping that they're going to be perfectly normal for many, many years. But that helps as well, because once we do see maybe there's muscle atrophy on the left hind limb, we know that that's new and we have to look into it. So it's a really important part of the physical exam. But I know a lot of clinicians that either don't have the expertise to do it, and there's easy webinars you can watch and lots of places you can go to learn about how to do this. It should be part of their general physical exam.
Sure. I think that's great advice. And I'm thinking from a GP standpoint in a hospital setting or something like that. So many times I'm sending off blood work on my patients. And so we'll walk outside to get urine to send that off with the panel. I feel like that could be a really good opportunity that you have to walk the dog outside anyway. So walk outside and watch the gate. And then the orthopedic exam that you're talking about, when you talk about, okay, feel every joint in the body and check flexion and extension and abduction and things, putting your hands around it, it can sound like a lot, but in reality, how long would you say that hands-on portion of the orthopedic exam takes you?
Really, once you get used to it, you can complete it within 5 minutes and maybe even less than 5 minutes, because really, if it's a tractable patient, you can get that done very, very quickly.
It almost becomes, I'm picturing like second nature. I feel like when I have a dog standing on a table, if they are on the table versus on the floor, facing me, and I'm just kind of petting them, my hands naturally go to those lymph nodes and just start palpating around and things. And so it seems like one of those where if you do it enough times, you just get that muscle memory and you've almost kind of done it without even thinking about it.
Exactly. And the one thing, though, where we get into trouble there, early in my career, I had a lot of clients that I was friendly with, and I would always just chat with them while I was doing my physical exam. And I'd find by the end of the 15 or 20 minutes, and I'd say, okay, everything's okay. And they'd say, did you really examine my pet? Because we were talking. I wasn't telling them what I was doing. Now what I do is, yes, we want to talk to the client. We want them to trust us. So yeah, there's a lot of chatter in the first 5 minutes, but then I'll say, okay, now we're going to focus on Bingo, your dog. Okay. And I tell them play-by-play analysis basically of what I'm doing. And a couple of things. Number one, the client perceives value, right? And they don't mind spending money if they perceive value for what they're getting. And so I do that, but I also try and train the client to watch for that. What are we doing? Well, I'm checking his joints. Okay, what can I do at home to make sure he's doing okay? And give them tips and things through that. So making the client part of the team really, really enhances compliance. And good compliance is good business. It's not all about business, but if we can create and retain compliant clients, our practices are going to be successful.
I think that's a really good reminder. I too have been in that position where it's like, did you even do the exam? So I agree, trying to kind of narrate as you go. And I like what you said about directing their attention to say, okay, now we're going to focus on Bingo and I'm going to turn my attention here. I've also found if I just, have one of those clients that they just need to talk to you through the whole exam, coming back with a summary at the end of, okay, and these are all the things that I found on my physical and all the things that I checked on the way through that you might not have noticed I was doing.
And I think that's a wonderful way to do it as well, because there are clients that stop talking during and again, we're not going to stop them. We don't want to lose a client doing it that way. But I think your guidance there is perfect. That okay, let's take the last 5 minutes and I'm going to review exactly what we did, and that client's going to say, oh yeah, I did see you doing that part. And there are clients where we don't have the option except to give them the results at the end.
Sure. But such a good reminder to make sure that we're communicating that value, because certainly there's a cost involved and we want owners to understand the value of what they're paying for. As we're doing this orthopedic exam, I think another thing you said earlier that really hit home for me was we talk to our clients and we say, how are they doing? The client says they're doing great. And we say, okay, that sounds fantastic. But like you mentioned, they might not necessarily know what specifically to look for, what's normal, what's abnormal. And so having some of these objective measures to really determine is there pain so we can catch it early and address it is important. And then pain scoring is, of course, one of those tools that we can use. So can you review some of the resources that we have available to get a pain score on a patient and how we use them appropriately in a physical exam?
Yeah, and it is critically important. And again, we do everything else in our physical exam, but sometimes we don't do pain score. And pain score should be part of our regular findings in the exam, and especially with pets as they're getting older, especially with large breed dogs, even when they're young, we want to assess that because again, it's very hard for the clients to perceive pain. Is it there or is it not? And so that's why I pain score every patient. And I like the scale, the 0 to 10 scale. There's lots of scales out there, but I like the 0 to 10. And again, 0 being no pain, 10 being maximum pain. And I do that in my exam. I will give a pain score for each limb. Okay, and even each joint if they have multiple joint disease. And I think that's really important. And it's become even more important as Librela has come to the market. And again, I don't want anybody to think that I'm saying Librela is not a good product. It's a wonderful product. But what happens is a lot of dogs that are lame and painful, the clinician appropriately uses Librela on the patient, and the client at the end of the first month, they're like, wow, he's a puppy again. Well, that's because he's been uncomfortable for several months, maybe several years, and they haven't identified it. And the Librela takes away, maybe on that pain score, maybe the dog was a 7 out of 10, and Librela brought him down to 4 out of 10. And that's great, but 4 is still too much. If somebody was giving me a pain score and I said, yeah, my pain's better, but I'm still at a 4 out of 10, that's not good enough. And that's where we have to bring other things into our bag of tricks. And again, in some dogs, Librela gets rid of all of the inflammation, especially if we catch it early. But most of our patients with chronic osteoarthritic disease, they will need something extra. And that something extra in my practice is most typically an NSAID. Again, some people would reach for other products out there, and there are many products that can also work with this. But really, the only thing that's going to take care of the inflammation is a good nonsteroidal anti-inflammatory drug.
And inflammation is what is responsible mostly for the progression of this disease. Is that right?
Correct. That's where the progression is going to go. And we may not be able to fully stop the progression, but we can at least decrease the amount of pain. So again, if we can get a dog that was it a 7 out of 10, got Librela, now is a 4 out of 10 with an NSAID, get it down hopefully to a 1, then I'm happy. Occasionally, it doesn't go far enough, and we have to add other things in. But the majority of patients, in my experience, will do very, very well with that NSAID along with the Librela. And there's many NSAIDs out there. I prefer to use the licensed NSAIDs. A lot of people don't realize when a generic product comes to market, that generic doesn't have to do any safety studies or efficacy studies. All they have to do is to prove bioavailability. So if they have a product, again, Metacam is my go-to NSAID. I practice in Canada. It's a very, very popular drug in Canada and in Europe and Australia and New Zealand. It's a very, very powerful and welcome product. And so Metacam at 1.5 milligram per mil, they had to do millions of dollars worth of research to prove efficacy and safety. When generics come in the market, all they have to do is prove there's 1.5 milligram in each mil of the product, and the product can come to market. And with a product like an NSAID, we have that narrow therapeutic index, and that worries me. And of course, NSAIDs are probably one of our most dangerous products that we use, especially if we don't use them appropriately. And what I mean there is there's a thin line between the drug being safe and effective on this side and the drug causing side effects on this side, as clinicians, we need to make sure we're on the right side of that narrow therapeutic index. And that's why I like to stay with what I call the pioneer products, the products that have been licensed and gone through all of the safety and efficacy testing, not just to be able to tell there's 1.5 milligram in each mil.
Something I can say I never really thought about, when we're talking about this stuff, I went 1.5 mg per mil is 1.5 mg per mil. I never really considered like the safety studies and bioavailability and things like that. So I think that's a really good point that you bring up there.
Yeah. And it's, again, a lot of people, and we're good-hearted people in this business, right? And if we can save a client some money and a new generic comes along, and again, a lot of people will say, well, let's switch to that because I'm going to save Mrs. Jones some money. And again, there's nothing wrong with that line of thought, except, especially with NSAIDs, there's such a narrow therapeutic index that I want to stay with what I call the pioneer products.
Sure. Yes, because you're right. These NSAIDs do have a very narrow therapeutic window. I mean, talking about especially like combining the NSAIDs with Librela, it just kind of makes me like my joints feel better just thinking about it, but certainly not if we're getting outside of that safety window.
For sure.
I want to circle back around to that experience in the exam room with the pet owners. We talked about pain scoring and doing the orthopedic exam. Can we talk a little bit more about gait assessment? At least in my experience, speaking personally, I feel like I underutilize gait assessment, gait analysis. And I think that's, it goes back to maybe not feeling incredibly confident in my ability to assess these patients. So can you talk a little bit more about gait assessment, how to do it, what we're looking for, and ways to really get an effective assessment?
Yeah, and it is a difficult thing because we're not taught that much about it in veterinary school, especially with dogs, and almost nothing with cats. And again, cats, a whole other issue to get into. And it was interesting because when I was in veterinary school and we were looking at gait analysis in dogs, I was thinking, boy, I'm not seeing this. And I had classmates that were going to be equine practitioners, and I'd see them jogging the horses, and I'd say, what are you looking at? And they tell me, and I say, okay, I see that, I see that, I see that. And I use that, learning a lot from watching horses down a runway to see how they're progressing, and moved it to dogs. And so it is important. And again, dogs hide their illness very, very well. They hide their soreness very, very well. And really what I do with the clients, and I tell them exactly what we're going to do. I want you to take them for a light walk to start with. Okay, you'll walk 20 yards away from me and 20 yards towards me. And then I'll often do that twice. And then if they're capable, I'll have them jog a little bit faster and see what I can pick up. But watching these subtle things, a dog, they can hide their problems very, very well. But usually by the time they're jogging, if they are uncomfortable, you will see something in their gait that is abnormal. And it might be one of the hind limbs is dragging their paw, and we're seeing that. Or it's not moving forward as much as the contra limb is doing. And it takes a lot of time to look at that. But once it's part of your workup, it's actually quite easy to do. So I went from not knowing anything about it to watching the horses to doing it with dogs. But it just takes, and especially if they're not doing this now, take a little bit more time. Maybe instead of 5 minutes, take 10 minutes and just get used to it. Or staff dogs that are in, and you say, hey, can you do me a favor? Can you run your dog back and forth? Because they'll start to pick up these subtle things. And these subtle things can be just a misstep. Could be that they're not fully extending a forelimb. So there's any number of things to watch for. But with a good gait analysis, you can get a ton of information.
So it sounds like what you're saying is a lot of that skill and confidence with gait analysis is just going to come from repetition, from just watching lots of dogs move.
Exactly. And if you never do a gait analysis and then you see a dog that you think might be lame, you might miss things because you don't know what you're looking for. And again, just like anything, looking at normal is really important as well, because it's hard to identify abnormal if we don't know what normal is. And again, after the gait analysis, of course, all of the work on the limbs themselves. But again, 5 minutes in my practice, maybe even less than 5 minutes now that I do it a lot, that gait analysis can get me that information. But clinicians that haven't been doing that, it's not that they're never going to get it. They're just going to have to practice it a fair bit to start with.
I think you're describing like every forelimb lameness case I've ever seen. Somebody comes in, they're like, it's a forelimb lameness. I'm like, oh no. I feel like those are so subtle. Do you ever use tools, maybe like taking out your phone and doing like a slow motion video or something like that?
Yeah, or I've had clients that actually identify a lameness, but their pet doesn't show it to us while we're doing this gait
Yes.
analysis. Right. And so that's where the phone comes in handy. And often they know what they're looking at. They film it and I get the information and we go from there. So it really, the client has to be part of the team. And they really appreciate that. Again, and I'm not going to lie to them and say, oh, I see something. But if they say, I see it at home, I can't see it here, then yeah, get video at home.
Sure. Absolutely. Yeah. Isn't it great that we carry supercomputers in our pockets and can just send all this information so quickly to each other?
Yeah. And one of the surgeons that I worked with when I was a veterinary student almost 40 years ago, they said a goniometer is your friend as well, because that's so important to assess joints. And so that's, again, I think we all got goniometers early on in school. They're probably lost to most people. So get one, because that's really important as well.
Yes, I have to say, I just recently started carrying a goniometer. I think because of just so much conversation and so many options around management for osteoarthritis, I went, man, like we absolutely need to be catching this early because there's so much we can do now to help slow it down.
Definitely part of the picture and part of the looking for everything we can in that pet. And again, a lot of times we miss things, and by the time we catch them, it's late and we can still help them, but we could have helped them a ton more early on.
So along those lines, one of my favorite words when we're talking about osteoarthritis management is multimodal, because it really speaks to the vast number of options we have. Can you kind of talk to us about how you approach these osteoarthritis cases, especially in the early stages where you are catching these early, and how you take that multimodal approach?
Yeah, and again, Librela sort of changed the system. And if I did identify an osteoarthritic dog, that right now would be my first go-to. Okay. And the problem is we don't want to throw a whole bunch of things at the dog at once, because then we don't know what is helping the dog, right? And maybe we're using products that aren't helpful. As I mentioned, though, the majority of my dogs on Librela, yes, their pain score will come down, but it's still going to be too high. And that's when I'll add in the NSAIDs. And in my practice, it would be Metacam and Previcox. Then, if they're still not doing great, then that's when the nutraceuticals come in and other products like that, as well as are some of the other modalities. We have physiotherapists now looking at dogs. So the more of those things we can bring in, the better it is for the pet. But I start out one at a time, because again, if we throw 6 different modalities at the dog, then we're wondering, well, which one was working? And the client's saying, this is getting kind of expensive. Is there anything we don't need? So I prefer to go from the first to the second to the third and move up that way. And CBD probably does have a role somewhere down the road as well. And there's all of those things. And the nice things about those other modalities is that can help us decrease our NSAID use as well. Because again, NSAIDs have a great place, but if using those, none of the other modalities that we're using other than Librela are going to be, number one, anti-inflammatories, and number two, pain relief. Okay. But a lot of those other products will help. And so again, I go step by step.
Okay. I'm really curious to know if you flip that approach with maybe some of these really early diagnoses that maybe we catch a lot in general practice, where just, a little bit of popping in that hip that we palpate or a little bit of crepitus in that stifle, but we can't really appreciate anything clinically. The owner's not reporting anything. We're not really picking up on any lameness because my brain, when I'm addressing inflammation, would say, okay, if I have a dog who appears non-clinical and I put him on, you mentioned the nutraceuticals, like a fish oil that's going to interfere with arachidonic acid, am I getting some of that anti-inflammatory effect without putting him on pharmaceuticals? And similar to some of these other nutraceuticals designed to interfere with that inflammatory pathway, what are your thoughts on that?
I think that the products can be useful, but I don't want to use them too early because they really are not analgesics, and we need an analgesic there. My goal would be to add them in again as a third tier. So we're on Librela, we're on Metacam or Previcox. If we're still not there, that's when I'll add in those other products. And that's when physiotherapy and all those other modalities will come into play.
Sure. And I love that you approach it in tiers. I approach it very similarly because, yes, it can be overwhelming both conceptually and financially for clients if we're like, here's all the things we can do.
Yeah. And the other issue with some of the nutraceuticals is our clients want their pet to get better, right? And they'll start something and in their mind they're getting better. But have we pain scored them? Have we done a gait analysis and all that? Again, in most of those cases, that nutraceutical is not going to take 100% of the problem away. And in fact, unless they have Librela and NSAIDs on board, they're probably not going to do very much in my experience. There's a large placebo effect in that case.
Sure. I could absolutely appreciate that. What about Adequan? Do you incorporate Adequan into your osteoarthritis plans?
Well, one thing in Canada, we haven't had Adequan for about 20 years. We did have it before that, but for some reason it went away on the Canadian market. It is now back. And yes, so it is something that is one of the next things I will use if we still need more help. And again, probably before a nutraceutical, Adequan would be something that I would use.
Okay, that makes sense. So we talked a lot about the use of NSAIDs and how important and how valuable they are when it comes to managing patients with osteoarthritis. But of course, there's that safety margin that we always have to be aware of when we're using these drugs. How do you kind of go about dosing your NSAIDs? And I think it's always a question in my mind, at least, of like, how long do I put them on it initially? When do I go to daily use and all this kind of stuff? So how do you approach the course of NSAID treatment?
Yeah, great question. And I think number one is if it's an acute injury, then I will usually manage it with an NSAID. And again, in that case, Librela doesn't have a place because this is an acute injury. And so then I will use, and again, my NSAIDs are Metacam and Previcox. I like to have one liquid and one tablet, and clients like that. I don't need 6 different products on the shelf, so I have 2. And Metacam is my go-to product. Typically, I would, again, depending on how bad the injury was, if it's a significant injury, I'll probably go for 2 weeks with the NSAID. If it's a mild sprain, I would probably go for a week because NSAIDs, if we don't have to use them, it's better not to. That said, for the chronic osteoarthritic pain, NSAIDs will most often be a part of that. And one of the things that I really like about Metacam is the ability to titrate down to each patient's individual dose. I tell clients, I say, this is the label dose for this product, Metacam, and that's for average dogs. But Bingo isn't an average dog, he's Bingo. So what I tell them is a protocol that I developed for Boehringer Ingelheim probably 20 years ago now is what I do is I give the labeled dose daily. And so again, this is for chronic osteoarthritic pain, not for an acute injury. For chronic osteoarthritic pain, what I do is I'll give them the labeled dose for 4 weeks. And then at the end of the 4 weeks, if they're doing well, I'll start slowly decreasing the dose. And that's the beauty of Metacam is the liquid formulation allows us to titrate down very, very slowly. We can do it with tablets, but if a tablet We can't say, okay, a tablet's working. Let's try 15/16 of a tablet. We can't do that, right? We have to make big jumps. Whereas with Metacam, we can. And so for a large breed dog, using 1.5 milligram per mil Metacam, which is the light purple box, if it's a 45-pound Springer Spaniel, I'll give the 45-pound dose daily for 4 weeks, checking in with the client once a week always. Okay. If they're doing great at the end of the 4 weeks, I'll decrease it by 5 pounds each week on the syringe. So if the 45-pound dog was doing well for 4 weeks, we'll go to the 40-pound dose. If they're doing well for a week, I go to the 35-pound dose. If they're doing well for that week, we go to the 30-pound dose. If they're still doing well, go to the 25-pound dose. And I get the clients to keep charts of where the pet is. And if they haven't had any problems, we're down at the 25-pound dose. And maybe halfway through that week, all of a sudden the lameness comes back. We say, okay, 25 is too low. We bump it back up to the 30-pound dose, and that's their maintenance dose moving forward. And clients love that. They, number one, like to watch how their pet is doing. Number two, they don't want to use more medication than they have to, and that's why the titration works. Clients really get into this, and they send me spreadsheets with how much they're giving depending on the dog's activity that day. And often they'll say, yeah, he only needs the 30-pound dose unless we're going hiking on the weekend. And hiking on the weekend, we give him the full 45-pound dose before we hike, and he doesn't have a flare-up. They get really good at doing this, and they're part of the team. And again, if we can get by using less medication, it's the client wins because it's less expensive. The clinician wins because they're using it for longer, but most importantly, the pet wins because we're aiding their osteoarthritic pain. And so that's why I really like Metacam for small breed dogs. They have the 0.5 milligram per mil, the dark purple box. And same thing, if I have a 7-pound Yorkie, I'll start them at the 7-pound dose. If they're doing well, I drop on the syringe. So the syringe for small breed dogs is calibrated in 1-pound doses. So if the 7-pound works for 4 weeks, I'll go to the 6-pound dose. If it's doing great, 5-pound dose. If they're doing great, 4-pound dose. If we go to the 3-pound dose and they become lame again, we know the 4-pound dose is where we have to stay. The nice thing is we know if either the big dog or the little dog, if their arthritis gets worse as they go, we have room to move up without going above the labeled dose. And so that's the protocol that I've developed, and it's really helped their pet and helped the team member, because again, the clients are more compliant. When we make them part of the team, compliance goes through the roof.
I really never even thought about tapering that dose. And I also love the duration that you're mentioning here. I always appreciate, conversations with veterinarians who are involved specifically in rehab, because I think sometimes, at least for me, and I hope I'm not all alone in this, but maybe we do get a little gun shy of NSAIDs and don't use them for a long enough duration. So I love that recommendation for 4 weeks, because, when I do say, okay, we're going to stay on this for a while, I agree. Those longer durations, the pets seem to do better. And I never really considered tapering. I also love using Metacam in my patients. I think they do really well on it, but I hadn't really thought about tapering it, and that makes a lot of sense. Now, are you teaching clients to pain score these pets at home?
Yes, I am. Again, a client that's interested in doing it. Again, you don't want to
Sure.
twist somebody's arm if it's not their thing, but the majority of clients will be able to do that. The other thing I do with all NSAIDs is on the label, I put give only if eating and drinking, because a lot of clinicians put give with food. That means something different. I train the clients that if he's not eating or drinking, or she's not eating or drinking, stop the NSAID right now. As opposed to what used to happen is they'd say, oh, she's not eating or drinking, I probably should increase the dose, right? And then before you know it, there's a disaster happening. So that little comment on the label, give only if eating and drinking, that's, I think, a critical thing as well.
Yes, that's such a good reminder. I try to have that conversation verbally with people, but I like the idea of putting it on the label, especially when we are talking about chronic use.
Right, because most of the time they'll call and say, hey, it didn't have anything to eat or drink today. What should I do? Well, number one, stop the NSAID
Right.
and let's get them in because it's probably not NSAID related. But if we don't do anything for 5 days, NSAID's going to get blamed for sure. And so it's really important that they're on top of it. And again, I try not to scare them at all, but I do tell them that this is a medication, just like aspirin, that can upset your stomach, and we don't want to keep giving it if that's what's going on. And so again, making the clients part of the team really, really helps that.
Sure, sure. Well, Dr. Joffe, I feel like I've learned so much in this conversation. And, osteoarthritis it's a big topic. It's something, that we cover from a lot of different angles, yet somehow in every conversation, I learn a different approach or pick up on different techniques and things that we should be talking about and doing in the exam room. With all of that in mind, I'm curious to know what's the one takeaway in this conversation that you feel is super important? What's one thing you wish everyone would remember about osteoarthritis?
I think the most important thing right now is that we have great products out there, but we can't just rely on the one product. We shouldn't say, take this, everything's going to be perfect. Maybe they will, right? But that's good. We need to reassess. And that's the one thing. Yes, we have great products on our shelves now that we never had before, and they can do a great job, but we still have to monitor because our pets can't talk. They can't say, I'm still hurting, because if they go from a 7 to a 4, they're going to be feeling great. So we still have to reassess. And I think that's the most important point.
Absolutely. And I love the emphasis you gave us in this talk on those objective assessments, not necessarily taking our client's word for it, which I know I've absolutely been guilty of.
With my own dog, I'm guilty as well.
Sure. Well, Dr. Joffe, thank you so much for joining me. This has been a great conversation.
Thanks for having me.
Thank you so much to everyone who tuned into this episode. Like I said in the introduction, I hope you also are able to take away some really great tips on the role of inflammation in osteoarthritis and how we go about effectively addressing that inflammation. A huge thank you to Dr. Joffe for all of the wonderful information. Thank you so much for joining me. And thank you to Boehringer Ingelheim Animal Health for making this episode possible. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals like you find this and other great content we try to put out there. For more episodes like this, click on the Education tab on the VetFolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassie DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day. Important safety information for Metacam, Meloxicam, and Previcox. Previcox, Furacoxib. Chewable tablets are for use in dogs only. As a class, cyclooxygenase inhibitory NSAIDs like Previcox may be associated with gastrointestinal, kidney, or liver side effects. Dogs should be evaluated for pre-existing conditions and currently prescribed medications prior to treatment with Previcox, then monitored regularly while on therapy. Concurrent use with another NSAID, corticosteroid, or nephrotoxic medication should be avoided or monitored closely. For more information, please see full prescribing information. Metacam, Meloxicam oral suspension, is for use in dogs only. Metacam, Meloxicam solution for injection, is approved for use in dogs or cats, not indicated for osteoarthritis in cats. Repeated use of Meloxicam in cats has been associated with acute renal failure and death. Do not administer additional injectable or oral Meloxicam to cats. As a class, cyclooxygenase inhibitory NSAIDs like Metacam may be associated with gastrointestinal, kidney, or liver side effects. Dogs should be evaluated for pre-existing conditions and currently prescribed medications prior to treatment with Metacam, then monitored regularly while on therapy. Concurrent use with another NSAID, corticosteroid, or nephrotoxic medication should be avoided or monitored closely. For more information on Metacam solution for injection and Metacam oral solution, please see full prescribing information.